Unless we fix what's broken in our current system, everyone's health care will be in jeopardy. Unless we act, premiums will climb higher, benefits will erode further, and the rolls of the uninsured will swell to include millions more Americans.
All right, President Obama's health care reform plan is a massive undertaking. 2 committees in the Senate and 3 in the House are already working on proposals. Among the goals, extended health care coverage to some or all of 47 million uninsured Americans, and obviously cutting costs. Among the proposals, a public plan to compete with private insurers, I should say. Pools uninsured people can opt into. We're going to talk about that. Mandated coverage with possible tax credits as an incentive. Taxing some employers that don't offer coverage. Incentives for use of techniques, drugs, and services deemed most effective for the least cost, and taxing health benefits for the first time. Obviously a lot of very complex issues here. It is a serious undertaking, to say the least. Joining me now to discuss the future of health care in America, Scott Gottlieb, a former FDA Deputy Commissioner, former Senior Policy Advisor at the Centers for Medicare and Medicaid, and a physician at Stanford Hospital. Also, Bloomberg's Michael Waldholtz, Managing Editor for Health, Education, and the Environment here at Bloomberg News. And live in Stamford, Connecticut, Barbara Ryan, an analyst at Deutsche Bank Securities who covers drug companies. Thank you all for joining us today. Let me start with you, Scott, and ask you, how long do you think this will take? Is this something that you think we will actually get passed by the end of the year, as President Obama seems so optimistic about, considering how complex and how difficult it seems to all sort through?
Right. We will see legislation this year. The Congress needs to pass a Medicare bill to create some technical fixes in the Medicare program, and a lot of things will get attached to that bill. The question is, does the president get what he wants, which is a big expansion of a government plan to try to get more of the uninsured people who are currently on private insurance, into a government insurance plan? That's really the question mark. And there's 2 bills that get passed this year. There's a bill that gets passed with 61 votes in the fall, or 62 votes, and gets some Republican support, and another bill that gets passed with 51 votes around December or January. And that would be a bill that wouldn't have any bipartisan support.
So it's the coverage that's at issue here. Michael, a lot of talk about how much more this is going to cost us. The president is saying this actually cuts costs. It's kind of hard to sort through which is the case.
Well, it's hard now because the scoring, so to speak, from the Congressional Budget Office is unclear. Last week we had a glitch after the Senate plan that was proposed came in at a lot higher than anyone expected, and that bill, which is being proposed by Senator Baucus's committee, was pulled back. We're expecting to hear that bill come back out again this week. The big problem with that was the public option, which the president seems pretty adamant about. He was adamant about it again today in his press conference, saying it's critically important to hold down costs. And the idea is that a public plan, which would cover a lot of the uninsured, would be very competitive with the private insurers and force them to be as cost conscious as possible, probably doing a lot of preventive health care.
I want to talk about that, but I want to bring in first Barbara and talk a little bit about how we're going to save money as far as the big drug makers. Obviously, that's a huge part of cost here. There are a lot of pieces to this puzzle, but we got another piece of news today that they're going to cut prices, or at least not raise prices, by another $80 million in addition to what they've already done. How do you see the costs as being held back here, Barbara?
Obviously, there's a lot of focus on the cost of prescription drugs. They're 10% of total health care costs, but they have been rising faster than both. In addition, they are obviously, with the Medicare drug benefit, a big cost for the seniors, who are a big voting bloc, and for the states in Medicaid. And certainly the donut hole, which is the coverage level between $2,700 and $4,000 plus dollars in annual drug expenditures, has been, maybe one of the flaws in the Medicare Part D expansion, even though that program has been very successful. I think the pharma industry recognizes that healthcare reform is coming, and in an effort to be part of the solution rather than part of the problem, they are trying to work with this administration. They gratefully have the opportunity to work with this administration, and I think, have proposed a program that would address one deficit of the Medicare Part D program, which is the donut hole, and that is estimated to cost the industry $80 billion over a period of 10 years. Now,
will that plug the entire donut hole? And this is, what seniors, for example, face when they get to a certain level, they have to pay extra.
Right. Well, there are a couple of different issues here. No one has disclosed yet how much of the savings that would be generated from this $80 billion actually go to the issue addressing the donut hole, and how much of that is actually increased rebates to the government for Medicaid and for dual eligible. So we don't know those specifics of the plan yet. It will certainly help with the donut hole in that if you are on a branded drug, you will be able to purchase that drug at 50 cents on the dollar while you are in the donut hole. So it will reduce the burden. However, a lot of people currently within the donut hole discontinue their medications because they can't afford to subsidize the benefit during that period of time, or take generics, which are very, very inexpensive. So it does address the shortcomings of the bill, but still for the consumer, it will cost them a lot less than buying the branded drug in the open market today, but it still will be a net cost for them.
Barbara, it would seem that this might actually end up costing the government more money, because if you discourage some generic switching that would have otherwise happened, and you're also going to accelerate the rate at which people are going to enter the catastrophic cap, so then where the government's picking up most of the costs. So while this might save some consumers out-of-pocket expenses, it might actually end up costing Medicare more money, which begs the question. They're talking about getting $80 billion or more in savings from the pharma industry. It begs the question, what else was in the package that the industry negotiated with the administration? Some people are speculating that they negotiated away Medicaid best price on the dual eligibles and some other things as well. They just haven't announced those yet.
Right. I mean, you bring up, really the point here. I mean, I think the dual eligible, the Medicare members who fall into the donut hole simply aren't typically taking branded drugs, so it is a net cost. Or they're taking, to your point, generics, which are inexpensive. And so the devil is in the details. We don't know what has been agreed upon in terms of Medicare and Medicaid and dual eligible discounts.
All right, it sounds like Barbara or someone around Barbara has a BlackBerry. Hopefully we can get that figured out. We are going to take a quick break here, but we're going to continue. I'm going to come back and ask Michael Walholtz, for example, when did the insurers come in? We've already heard about the prescription drug makers, but there are a lot more pieces of this puzzle that are going to end up costing money. And I'm going to also ask Scott, if we do indeed spread coverage to the 47 million Americans who don't have coverage already, how could that possibly cut costs? Email me any questions or comments you may have, mtmiller@bloomberg.net. We'll take a quick break and continue talking about health care when we come back.
We have not drawn lines in the sand other than that reform has to control costs and that it has to provide relief to people who don't have health insurance or are underinsured.
All right, let's continue our roundtable here on healthcare. And I want to quickly touch on this donut hole issue because it's a little bit complicated. We were just talking about it during the break. The drug makers offer to cover about half of the cost beyond the donut hole. To me, I would think, why don't you switch to to generic drugs anyway, since they're only a fifth of the price and are the same, essentially, right?
Right. That's what a lot of patients are doing right now. When they're approaching the donut hole, they'll switch to generics to try to bring down their overall drug spend. But now that they're getting a 50% discount on the branded drugs, those people who might have thought that they would go through the donut hole
anyway... And the donut hole, let's just make clear for people who don't know, because a lot of people are just learning about it.
It's a coverage gap.
It's a coverage gap. You're covered to a certain point, say $1,000, but not up to $4,000, and then beyond that. So you have to cover the...
Right. It's a coverage gap, but then beyond the donut hole, the government's picking up most of the cost because you've reached what's called a catastrophic threshold. So when people go through the donut hole, it becomes very expensive for the government. And now what you're likely to see is more people accelerating through the donut hole into that catastrophic limit.
Well, if you're going to be in the middle of it anyway... Sorry.
No, that's all right.
Please.
Well, I think that what's unclear is exactly what is going to happen. And what, in fact, the question is what seniors are going to do. A lot of people don't want to go to a generic, go off a brand name, then to a generic, then back to your brand name. I think this is going to be one of those issues we're going to have to watch what people actually do. I think the bigger issue here is Obama trying to be very clever in sort of embracing an industry that in past has been against any kind kind of health reform. And I think one of the things you wanted to talk about is health insurers. I wouldn't be surprised if somehow he pulls that kind of rabbit out of the hat also. I'm not exactly sure how he's going to get the insurers to go along, but right now we know that the insurance industry is very, very uncertain about what it's really going to have an impact on.
Well, we saw how he did it with the car makers. They just owed him a ton of money, right?
Well,
and the health insurers could easily be in the same position.
That's right. I mean, you can argue that he embraced one segment of the drug industry because the biotech companies don't make out that well with the agreement.
That's actually true, and our reporting suggests that over the weekend, when this deal was cut, one of the companies, one of the people that were balking were the representatives of some of the big biotech companies. Like I'm not saying which.
Let me bring Barbara back into the discussion here because Barbara, you cover the drug makers, but obviously they're affected to a great degree also by the insurers. What do you think? I mean, can we bring this group? Can the president bring this group into the fray? Does he need to?
Well, I think number one, he already has, and I think that there's something in this agreement for both sides. It may, in fact, represent that healthcare reform, even in its early days, has hit some snags in Washington, and that to build momentum, it's better to lock arms and move forward with this important constituent. I think that the industry, perhaps avoids, in a spectrum, what could have been, a far worse outcome for them. And I think, as Scott said, it still remains to be seen how much of a cost this is to the industry versus benefit in the end. The cost of this is being calculated to the government at 100% of the cost of the drugs, even though the consumers are paying 50 cents on the dollar, and the cost of those products to pharma may be 10 or 20 cents on the dollar. So those numbers are not all the same for each party, but I think that it certainly, as Mike said, is indicative of the president looking for support for health care reform and bringing, the players into the tent, if you will.
I think Barbara nailed an important point, because by announcing this now, the Congressional Budget Office might assume this into the baseline, not give the president credit for any savings that might accrue from this announcement. So then it begs the question, why did they announce it? And I think it's because they try to build momentum politically.
All right, we're going to take a quick break here. I want to come back and talk about the level of health care. If we have a national health care plan, does that mean that we have to see the bar lowered for everyone, even though everyone's insured? We take a quick break here. Come back in 2 minutes with more on our health care roundtable. Stay with us here on Bloomberg Television. All right, welcome back to our special roundtable on healthcare. I want to kick off with an email that I got from a viewer. Let's go ahead and flash it up on the screen. Warren writes in and says, what is a healthcare co-op? Okay, you don't need to flash it up on screen now that I've read it. And I want to go first to a soundbite of Senator Conrad, and then we'll talk about that. Okay, it's a very slow motion soundbite, and maybe we'll come back to it in a second. But for now, since I have experts here with me, Barbara Ryan joining us again from Deutsche Bank. We have Scott Gottlieb here from American Enterprise Institute, and Michael Waldholtz as well. Though, why don't you just tell us about this co-op? Because it's interesting compromise between public and private?
Well, it's a good question. I don't think anyone really fully understands what they mean by the co-op right now. It looks a little bit like what President Bush proposed in the association health plans, where he tried to create pooling mechanisms inside states so people can come together and buy private health insurance. The difference here is that the co-op seems to be designed to be its own insurance plan. So it will be both a pooling mechanism as well as its own state-run or federally regulated insurance plan. But no one truly understands what it means. The first question Senator Gregg asked Senator Conrad when they briefed the senators behind closed doors was, this sounds a lot like what President Bush proposed.
Well, isn't it an effort not to have what is something would be perceived as a national health care plan plan. I mean, what the president is proposing, and he hasn't fully defined it, is some kind of a public option, something you could opt into that would be run by the government, much like Medicare is being run right now. The idea of a co-op is it just doesn't sound like that, even though it would be something that could be still funded by the government. My question to someone like you, because I know your position about this, is what's so bad about a public plan? I mean, Medicare does, I know you've expressed concern about Medicare, but most of the people we talk to as reporters really don't complain about it. They love the fact that they have access to doctors. They love the care. Why wouldn't a public plan be a good idea?
Well, the reality is the public plan will create a death spiral for the private insurance plans. The employers will eventually dump their employees into the public plan, and you'll see private insurance plans start to fold up. Now, people talk about Medicare as being an optimal type of insurance structure. Medicare really doesn't do any utilization review, doesn't do any disease management. It's really a sort of a decerebrate payer. It just pays claims. It's not a health plan in a traditional sense.
Do you really think United Health is just going to fold its tent and run away? I don't believe that.
I think you'll see the insurers start to shrink down. If you have a government plan competing in the private market that's subsidized and regulated.
United Health has shown that it can compete very aggressively in the Medicaid market, in the Medicare market. I know the folks there. You don't think they could try to beat a public plan?
Well, let me also bring up what, in Germany, you'll have everybody on the state-paid health care plan. Unless you make a certain amount of money, then you're allowed to opt up, basically step up to the private health insurance plan. Don't you think we would follow some sort of similar model?
I think what you'll see, if President Obama succeeds in having a government-run plan that starts to capture some of the current private market that you see in the United States, what you're going to see is a multi-tiered system. You have Medicaid, which is a very low-quality insurance. And in some parts of this country, you're better off being uninsured than being on Medicaid in terms of your ability to access the system, or it's just as bad as being uninsured. You'll have Medicare. You'll have a private market for people who can afford it, and that'll be premium coverage. And you'll have this public plan, which will be sort of a middle level of coverage, much like Medicare. Medicare is going to become a much more restrictive insurer.
I want to bring in Barbara. Barbara?
I just wanted to add that, from my understanding, I think that the critical difference is that if you had a public plan, that public plan doesn't have to generate profits for shareholders. It can have a fundamentally very different cost structure, and that's what's going to change the private market.
Well, it's also that, if you have a public plan that's government-run, I mean, let's call it a government-run plan. It's really what it is. It's like the government playing both the pitcher and the umpire at the same time. I mean, they're going to be regulating the entire market at the same time that they're subsidizing their own plan.
Although I heard the same kind of complaints. I've been covering the healthcare field since the mid-1970s, and believe it or not, the American Medical Association thought that the creation of managed care plans, HMOs, was communist. I mean, they were against it, and they fought it. They also fought Medicare.
There are a lot of people who still agree, by the way, as far as managed health care plans
go. But many people did very good.
I don't think the physicians are too happy with Medicare right now, or Medicaid.
Yeah, I mean, if the whole market went to Medicare type of reimbursement, you'd see a lot of physicians really get squeezed hard. A lot of physicians rely on the private insurance to make up the margins to keep their practices open.
Do you have any concern, Michael, about kind of a brain drain here? Because I notice in other countries that have national health care systems, the best doctors who hardly get paid enough to reimburse their college loans go to different countries.
Medical schools are still turning away applicants. As far as we can tell, being a doctor is still a very nice way of making a living. I think what we've got is an older generation of doctors who are very upset that the old way is gone. I think younger doctors are more willing to accept that that the kind of income they're making is going to be a little limited, a little different. They're not coming in with the same expectation.
I agree that the sort of complexion of the medical profession has changed. I think what we're losing sight of is that we're going to see a much different government with respect to the healthcare industry going forward. Up until now, Medicare has basically been a processor of claims. It's paid for everything. That's changing. Medicare is going to become a much more active purchaser of healthcare in that they're going to deny coverage for a lot of technology and a lot of services. And you're already seeing it.
But as a taxpayer, why wouldn't you want that?
But you might want that as a taxpayer in terms of cost control, but you don't want the decision-making to be that remote and that removed from the locus of care. If someone needs to make a decision with respect to incorporating cost into a decision, you want that to happen close to the physician and the patient.
All right, I got to unfortunately cut you guys off. We can continue talking about this after. We can go across the street and get a beer. I want to thank you, Scott Gottlieb. I want to thank you as well, Barbara Ryan from Deutsche Bank, and Michael Waltz, thank you as well.